Good morning. My name is Dr. Angie.
Good morning.
A great honor to be able to introduce Dr. Paloma, who is the 11th Vice Chancellor of the University of Guyana and Professor of Behavior and Communications. She has served as the Director of the Center of Communication Studies, the Dean of the Faculty of Social Sciences, Deputy Vice Chancellor of Philanthropy, Alumni and Civic Engagement, and Chair of Transitional Management Team. Dr. Martin has published extensively in social and behavioral change, communication strategy, education policy and practice. Personally, I remember my first introduction to Dr. Paloma Mohamed, her passion for students, her ambition for forward movement and change at the University of Guyana was compelling. And so without further ado, I thank you for your attention, as she will be speaking to us a topic on towards a transtheoretical ecological model of vaccine uptake in the country.
Good morning, and thank you very much. Can you hear me okay?
Yes.
May I share my screen with you, please?
Yes.
All right, let me see. All right. Okay, so good morning, everyone, and thank you for allowing me to join you this morning. I'm sorry I can't be with you in person, but this is the way we have to live now. But it does allow us to be to zoom around and be many places at one time. I am going to venture into fairly dangerous waters here, but I think that it's very important for us to give some attention to this question. I think some scholarly attention to the question that is plaguing the world, and certainly the Caribbean, around why it is that persons are not taking the vaccine. And my purpose here this morning is really to attempt to present a nuanced, non-hysterical analysis of what is happening, and to place the behavioral and social lens on uptake and on the problem, because we have been seeing quite a number of scientists, but these are, virologists and medical doctors and so on. But the voices of the social scientists are pretty much out of the global narrative of what is going on. And this is quite, I think, problematic for several reasons, because most of what we are dealing with is really a consequence of human behavior and their effects. Can only be mitigated by understanding that behavior and contextualizing it. I'm really concerned that the way in which we are speaking about persons who have not yet taken the vaccine would lead to further alienation, stigmatization, and it is quite fascinating to watch, but also troubling. A discipline and disciplines that have been against stigmatization for so many years, literally using language and creating a narrative that stigmatizes persons who have not yet taken the vaccine. So we would expect to see things like rage reactants and fatalism, yes, from those persons who have not yet taken it. And you will note that I'm saying not yet taken it, and I'm not using Antibacker, because that is problematic in and of itself. It is value-laden, and it is a stigmatizing term, which I think we should really think very carefully about. And that term is really what I am looking to kind of unpack in a certain sense. If we understand, of course, what's at play, we can do something meaningful about it. And I really wanted to indicate that, the prevailing narrative or the label of anti-vaxxer as irresponsible, ignorant, politically oppositional, that persons who are not taking the vaccine yet are out for, creating political sabotage. And this is not only in this country, but in other countries. And so there's some amount of subterfuge going on. There's a global conspiracy to undermine the vaccine, and there's fear. These people are all religious fanatics. They're all blind fatalists. And of course, the big question, this big thing that people do not trust, right? I think that this is careful and superficial and quite careless and superficial and quite frankly uninformed. And those leading it, of course, should be aware of what they're doing, because I think they are necessarily not doing this thinking about the negative effects of what they're doing. They're just trying to drive people to take the vaccine, but it really can lead to further alienation, stigmatization, and so on. The next big issue that we will see, of course, when we look at the data from the Caribbean, and I will go here to show you this for a second. If you look at the Caribbean from the data, this is CARPA data that I got on the 14th of November. And if you look at worldwide uptake, right, you will see that about 40% of the people worldwide have taken this vaccine, right? But if you look at the Caribbean, it's lower than that. And if you look at the disparity between those who would have taken both doses and those who have taken one dose only, you will see a thing that could possibly trouble us. And I think we've begun to pay attention to that. And that is the question of adherence. And within this context, we don't know how many of these people have really been taking this vaccine, but I'm not going to go there. But I think those in Guyana would know, in other parts of the world, some parts of the world would know that sometimes there's a faking of vaccination that has been taking place. The extent of it, we don't know, but this is another problem. So if you look at how many people would have not taken the second dose yet, we understand that there's this question of compliance. And then if we think about how many of these vaccines have to get a booster dose, within a very short space of time for certain populations, then the question of adherence is something that we also need to consider in the context of medical management of this problem. So why should healthcare professionals care about this? Of course, you need to know how to manage this situation. And if you don't know what is actually driving the patient's or the client's hesitancy or reluctance, or what is going on with them, not only at an individual level, but in the nested context of their social life, then it is impossible really to affect the outcomes and to help them. Of course, more than any other disease, you are on the front line, directly affected, exposed, at risk. And so the burden of taking care of people so that they don't harm you and your families is also that much greater. And of course, the burden of medicine is that it behooves us to do what is right and just, and to take care of people, even if they are not thinking of themselves in the way that they should. Because oftentimes when people are sick, they're not able to cognitively process properly what they should do, how they should do it, and they certainly do need assistance in this regard. So basically, the major thrust of this, sorry, these are my alarms that were supposed to tell me I'm on now. Yeah, so humans are not homogeneous. As you know, no two humans are alike, even though as a species, we are a species, so therefore there's a lot of similarity in there. But in terms of our behavior and our social context, we're definitely not alike. And so COVID has taken a great advantage of that that issue of the fact that we are not so much alike. So one of the things that I really want us to think about now is these models, because I recognize we don't have a whole set of time and some of my models are not showing up. Why is that? Darn it. Okay. So are you seeing my sidebar, or are you just seeing what I'm showing on the screen? Because for some reason, what is supposed to be on the screen is not showing up, but it's in the sidebar. So is it possible for you to see my sidebar? Can somebody give me a yes? Good. So then please pay attention to the sidebar. Oh, you're seeing the screen.
Advanced. Advance your slides and you'll see it.
No, it's no, it's the thing is not, there seems to be a corruption in the actual file. So it's only half of what I want to show you is showing up.
Oh.
That's what's going on. I have 3 more models in that photograph. Let me go back and see if that's
So
what
we do see a sidebar. We
you
do
do.
see a sidebar.
Okay, well, look at the sidebar, please, because you see there are 2 things missing there. So there are a couple of models that are out there that I'd like to try to address this morning very quickly. And one of them, the first one, is a social ecological model in which the individual is nested in a particular, I'm not sure why this is doing this, very annoying, but anyhow, the individual is nested
Paloma,
in, yes.
Paloma, if you go up to the very top where you see the little icons and you click on the icon for which shows the slideshow icon. You see the little slideshow icon?
Yeah.
Yeah.
Okay, let me see if that's going to work. No, it's not. It's the, what is happening here is that the slide itself is not showing properly. That's what's going on. See if I could open a different.
We understand. If you can also slide the sidebar over, we're looking at slide number 8. But when she makes it a large screen, you can't see it. We understand. If you slide the sidebar over, we can
Oh, let me see. I've never done that before, but I don't even know if I can do that. All right. I wonder if I could just open this again, but then that's probably going to take a minute.
That's
I'm sure.
You can look at slide number 8. We do see what you mean.
Yeah.
We're sorry that it's not.
Yeah. I'm very sorry about that, but I'm not sure why that's happening. I think I tried to add something just now and I think I messed it up. All right. So the slide bar. So I'm just going to speak to them anyway. So basically the social ecological models basically place the individual in the center of a series of complex and interacting spheres. So the famous one that was Bronfenbrenner speaks about the spheres in a particular way. So, you know, individual, micro, meso, and so on. I'm not going to confuse people with that. But technically, what you're seeing here really speaks to that in a simpler way. So the individual is here, and if you and then there's the interpersonal level where they're having their relationships with families, their significant others, and then we have community and socializing organizations like churches, schools, and so on. Then we have here the prevailing national context, so of policy. And here we have culture, and I would like to add, and sometimes I do, especially with regard to a COVID pandemic and any pandemic, an international system, another bar that is really directing, certainly for small countries like ours, what actually happens in every single one of these spheres. The other thing the other model that I wanted to show you, I wonder if I have another version of it here. No. Okay. So that model it's called a diffusion of innovation model, and it's been variously kind of modified in these last couple of decades. But most importantly, that model speaks about the way in which people adopt innovation. And one of the things that we have to consider is that the prevailing idea of the vaccine. I looked last night at our Caribbean Public Health Agency site and noted that there were several, scores of vaccines in preparation that are being considered, and several that have already been approved in the world, and certainly that are in use in the Caribbean. But of course, the question that is on everybody's mind, and I think the thing that is worrying most people, is the new technology. This is the new technology that has to do with the RNA vaccines, but there are others that are not using this. And all of the vaccines that we are using in our own country are not using this technology only. But the fusion of innovation models speak about how people will have will uptake new technologies. And insofar as some of the COVID vaccines prevailing narrative is that this new technologies out there that is untested and so on, I think this is an important consideration for us. So when we're communicating to persons, is this the only thing, the overriding thing about these vaccines only? Are there other vaccines that people who are concerned about, whatever they're concerned about the new technologies that they would use? And could those be made available, therefore, so that we can take care of those persons? So diffusion of innovation models will basically say to you that there's a Gaussian graph that shows on the one hand, the Gaussian graph, which is the bell curve, and most people know it as, will say to us that there's a small number of persons who will be innovators. They will jump on, they're high risk takers. They will they will try any new innovation quickly. They'll be the first. And then there's about a double. So this is about 13% or somewhere like that. And then another set who will be early adopters, who will look on to see what these first set did, and then they will adopt based on what their evaluation of the risks and other conditions are. Somebody has introduced a very interesting modification to the first diffusion model that we had, and that is the idea of chasm, and that the next step is not as easy and smooth as would have been thought of in the past, because the next step in this model is that you are actually looking now at these people who will adopt after. So they'll be slow on the uptake, and that's a bigger number of people, maybe 20%. And then the graph, starts to curve downwards. So people who are going to take a longer time because something is happening. And then they have what they call the laggards, the people who are not going to, they're going to take a very long time. And that model stops there. But I would like to posit that really there are some people who will never be convinced and actually will never take up a new innovation. And we just have to understand that, and to spend our energies working on those who we know we can change, and understanding why. So the Transtheoretical model that I wanted to show you is a model, people use it a step to show what it looks like. And this is a model that really tries to explain how people make decisions, certainly about health, and it's been applied in other areas. And really, I have mapped it onto the same, the diffusion of innovation model, as well as the social ecological model. I tried to put them all together to just kind of show you in a way how they interact, and how we can probably understand what's going on with COVID with regard to them. Of course, this slide will not show. I hope the other one will show, and it's my very bad drawing, but I hopefully, it shows. But now, of course, you don't understand this. So let me explain. So at the bottom here is, of course, I've tried to replicate the bands for the social, the social ecological model. So they have the bands. So you have the individual, the micro, meso, exo, and macro. And of course, at the bottom here, I'm saying the macro, extended macro to the global. So this is what I've explained in the middle, these circles here. Over here, we have the diffusion of innovation model. So you have the early adopters, the ones who are looking, the second, those who are loafing, and the others, the laggards. And then I said, never take over here. And then over here, you have those who are really not in the bottom. Again, this model assumes that people are they're in pre-contemplation. But in our situation, there are still people who do not know about COVID, and really they don't, and that would surprise everybody, or they don't know much. And if you don't know, then you can't be pre-contemplating anything, because you really are in denial, or you don't know. But you have those who are in pre-contemplation, so they're thinking about what to do, if they can do it, how they can do it, and so on. Then they're actively contemplating. So you know, I have to do it, and they're planning now how to do it. And then you have, they will actually work on doing it, they will act, and then they'll maintain. And then some models are talking about those who will fall off the wagon, and where there's no adherence, or they're going to not, they're going to relapse. And so this was my very terrible drawing, which was going to be look much better with the nice models that we're showing. But what I wanted to show is this. I flipped this model on its head. And this little person at the bottom here, this is little Paloma here, but it's a person, an individual. And if all of these pressures are coming to bear on an individual, right? So they're trying to figure out what to do. They have a social context that may be constraining them, and so on. They have issues with work. They have conditions that they have. And so really and truly, you could see here the pressure on an individual to make a decision about something. It's not a simple thing. So when we are being hard on people about not doing this, not doing that, calling people anti-vaxxers, asking, this is not showing up either, darn it. All right, let me go to, I need to close my presentation and start again, because none of these graphics are showing up on the actual slide, but maybe I can just go to the last one and see if it can show. Hopefully this one does. Okay, all right. So I'm just going to, these were just some, what I was going to show you some data on the Caribbean and the rates of uptake, as well as what's happening in terms of population. Oh dear. All right, I'm going to stop the slideshow and start it again, because the whole thing is not behaving well. So I'm going to just start my PowerPoint again. So let me see, stop share. Have you stopped? Has it stopped? Or are you still seeing my screen?
Stop. Okay,
good. So I'm just going to try and start it again, close the PowerPoint and start it again, and see if that will solve the problem. I moved from one room to the other with my laptop open, trying to get to, so maybe that's what it is. I might have done something to my flash drive when I was moving, so let me see. Okay. Presentations, see, today. Okay, if not, I have a hard copy. All right. Let me see if I have better luck now. Okay, I'm going to share my screen again and see if that is going to work this time. And I see, are you seeing everything okay now?
Not yet. Yeah.
Yes.
Yeah, great. Okay, so I'm going to go from beginning and then, all right. Yes, lovely. So, okay, now you're seeing. So I've talked about these already. So this is the diffusion of innovation model that I was showing you. So you wouldn't recognize it from my drawing. I can't draw, but this one is the social ecological model. And this, of course, is the TTM model. And this is a chasm diffusion model that speaks about really having to get past this right here. Get past these from the early adopters to the early majority. It's a big step. And if you see where we are in terms of numbers, you see that we are just around 30–40% in the Caribbean. So we are really in a position where we are struggling. I showed you that already. I wanted to show you now, because the Caribbean has a problem with a chronic, I think we're leading the world with diabetes and hypertension. This question about whether or not a person is at high risk of death or serious dysfunction and harm when they take a COVID vaccine is a very big I think, key to unlocking why people in the Caribbean may not be taking this vaccine as they should, because there's a prevailing myth out there, an idea out there that persons with hypertension could develop a stroke or heart or a blood clot in their heads or something like that. And if you have high numbers of persons who are hypertensive in the region, all across the Caribbean, this is speaking to this and helping them to understand that, first of all, they're at risk for COVID if they're hypertensive, but also that if they may actually, there's no reason for them to be concerned about their own health in taking the vaccine. Well, or what are the risks? Some people, quite a number of people in that pre-contemplation stage are trying to bring their blood pressure down before they go to take the vaccine. And of course, you know that is a very difficult thing to do, to maintain if you've been hypertensive for a long time and if you're anxious and so on. So really and truly, this is something that we need to consider in our public messaging and our outreaches about the Caribbean. That is, I think, going to help us. The other issue is the high rate of undiagnosed but diagnosed anxiety in the Caribbean and depression. The University of Guyana in 2020, as soon as the outbreak reached Guyana, we started we did several things, but I'm speaking only to the hotline, the UG hotline, which the social work students and psychology students managed to man, and in fact, some of them are still manning those. And from their reports, there are quite a number of reports of intimate partner violence in the first instance, suicide ideation, anxiety, depression, family conflict. And I want to draw your attention to this part of the world where the families are fairly extended, right? So you have nuclear families, but you have a lot of extended family pressure on persons. Look at this: family conflict due to non-adherence to COVID-19 regulations. Now, that's one thing, but we also have reports of family conflict due to people not wanting the other members to take the vaccine, and where persons have snuck out and have covertly gone to take the vaccine and others have found out. And this has been a major problem for persons. Also, again, because of the closeness of our and very complex kinship ties in our country, small country. What happens with one person seldom ever goes unnoticed and unknown by the others. It's just a matter of time. And so any kind of supposed effect of this vaccine, even if it was not an effect of the vaccine, and we really cannot tell, is something that we have to consider, because persons remember that curve. They're looking on to see what has happened with other people, what their experience is, before they continue on to make a decision about what they have to do. Also, the fear and risk of persons even having 2 or 3 days ill, because people have work and they're concerned about not being able to manage their livelihoods and their lives, is something that we also have to consider. And one of the things that I am noting, even at this period, is that on the weekends, only few centers are open and available to the public certainly in Georgetown, because I did try last weekend, because I had some children I was trying to work with, and we found somewhere eventually, but there were not many places open. And so, of course, if persons are concerned about being sick, because we've heard that you have 2 or 3 days or 4 days where you are not feeling well, then taking the vaccine in the middle of the week, if you do not have a supportive employer, if you don't have volition over your own employment conditions, then that's something to consider, all of those things. Okay. So one of the things that is concerning and to be thought about for the future, of course, the high number of persons in the world who are older, who are getting very sick and passing away. And this, of course, was our population curve in our population graph in early 2021. But you will notice that we are now, for the older persons, we are, tapering off. And one of the things that the loss of so many persons who are, 50, 60 years old is likely to do to us. And we have to consider the roles of those older people in our societies, because many of these persons would be great grandparents given the average age of first pregnancy and childbearing in the Caribbean. And these people are the people who have been stabilizing, not only with their pensions and their money, they've been stabilizing many families of a certain socioeconomic bracket. And they would have also been passing on values and helping to discipline and care for children. And the loss of so many of them in such a short space of time is something that we really have to consider. What is going to happen with those kids and in those family situations and those social structures in the next few years. I'm going to come to a close, but I want to address this matter. So the point I'm making is fundamentally this. One, we are constructing our public narratives around three major ideas. So one is that there is no trust for the vaccines. And if we believe that this is the only reason why we are seeing a slow uptake, then it is leading us down a probably half-baked path. The second one has to do with religion, that everybody is believing that God is telling us not to take the vaccine. And that is also highly problematic in and of itself for all kinds of reasons. And of course, the third one has to do with, political opposition and the fact that people are not taking this vaccine as a signal that they don't trust or they don't want to work cooperatively with those people who are in charge of the process. I am not discounting those. There may be those, but look at this. There are 15 or so 16 areas, and I just did a kind of fuzzy model here. This is not actual. These figures are not actual, but they're kind of approximations. So in Guyana, we have. Let me close this. This is why you're not closing now. Okay. So we're saying that just around 40% of our people in the country are, 48% are either partially or fully vaccinated. So 31% fully vaccinated, we believe. But that, of course, we could talk about a little bit more. Partially vaccinated, 17%. Are they going to get vaccinated? So let us say this from the total adult population, this is 150,000 people. This is not the correct figure because I think it might be a little different, but I just approximated just to demonstrate something. Those who are not yet vaccinated, NYV is not yet vaccinated for me. This is my terminology, and I hope that people will start using that because it will prompt, it recognizes that everyone is not an anti-vaxxer and that there's several other things that we have to consider in terms of people not being vaccinated at the point in time, but maybe they're considering it. So let's just say that there's 170 people. And basically what I did is I created these 16 areas that people would be concerned about and just divided it by 16. And so in each one of those areas, you might have 10,000 people. You might have more. It's not an equal thing. The epidemiologists would know exactly how many people with, comorbidities we have in country. They would know how many are severely immunocompromised and therefore cannot take the vaccine. So this is like they can't take it at all, but is there something else they can do? And therefore, if there's something else they can do, we need to be able to promote that publicly and privately, and so that those persons will not be counted
Hello? Dr. Martin, we're unable to hear you any longer.
One of our very well-respected lecturers at UG, an older professor,
Dr. Martin,
who called.
Dr.
Yes.
Martin, we didn't hear you. It chipped out for a moment. So if you can go back to the epidemiologists will be able to speak to the comorbidities. We didn't hear anything after that.
Okay, I'm sorry. Thank you for letting me know. So maybe I should turn my camera off. Maybe if I turn my camera off, I'll get a better, let me see.
We heard everything else.
You're hearing now? Okay. All right. All right, good. So I was saying that epidemiologists would know in the country what the actual figures are, or what the better figures are for those with comorbidities in Guyana, right? So so they would know that these are the people, the targeted messages that they have to speak to about what their fears are, and how to overcome those fears with regard to getting either vaccinated or what they can do to manage and keep themselves safe. Then we have persons who are seriously ill and immunocompromised, so they can't take this vaccine at all. And again, this is a number of persons who, again, our public health system should have a sense of how many the total is, and therefore they cannot and should not be counted in the set of people who are supposedly anti-vaxxers or not vaccinated, because they can't be. Then we have persons with temporarily inconducive living conditions. And what do I mean by that? We have a very mobile population in this country, people who are, live, several different places for different reasons. They're not necessarily indigent, but some of them are. So there's the population, but there are people who live and work in different places or have different family arrangements that they kind of move around. But then you also have people in the context of the physical distance that is necessary for COVID, who is in conducive living conditions are imposed by COVID itself and what is required to be done. And in one particular instance, and there that I will share with you, we have had on campus a number of persons who were not showing any interest in taking vaccines. We had several outreaches for vaccines, vaccination days on our campus, and we had people taking, but not as many as we thought. And we kind of tried to figure out why. And one of the things that was immediately began to emerge is the age of the average university professor, and the fact that they were living alone, and the people who they were helping, who would visit and so on the normal circumstances, we're not doing that we're not able to do that anymore. And this great fear that if you took this vaccine and something happened to you while you were alone at home, you would die at home. And so these there were people who were waiting for family members to get vaccinated who were out of Guyana to come back. And when they came back, they then went and took their vaccine so that somebody was in the home there with them if something happened, to take care of them. So this is a really serious consideration. And this is not only for people who are elderly, but also people who may know they're ill and who may have anxiety and all of those kinds of problems that would, of course, be exacerbated by this situation. And then there are situations where people are being coerced into not taking the vaccine. In many cases, you have couples where the one is has their ideas and the other one does not. And in situations where you don't have you're not able to get out of the home and have autonomy as much as possible because, again, of COVID conditions, you have people who are really not helping people to take to make the decision to take the vaccine. And you also have the others, but of course I'm dealing here specifically with those who have not taken the vaccine yet. There are access issues and capacity issues. You have people who are physically and otherwise disabled. We have problems with locations and problems with resources. it might seem to us that a person may not be able, and large numbers of persons may not be able to afford the bus fare or the taxi fare to get to a clinic and a center. And this is why a community-based approaches where, you know, the vaccine or the methods are or the medicines are taken to communities is something that is has worked in other places, and we should extend ours, because this question of economic barriers to being able to really maintain our own health is something that is great. And of course, we know that COVID has exacerbated that. The latest UNDP reports have indicated that about 44% of the country has lost either all or a great significant amount of their livelihoods over these last almost 2 years. And so that is something to consider. Of course, persons who are persons who are fearful, normally fearful of vaccines, hate vaccines, but also fearful of all the things, and this overload of all kinds of scientific and non-scientific information that's coming. So this exacerbates that. So how do we address people who are fearful? Do we then abuse them and call them ignorant, anti-vaxxers? Or do we address their fears and try to understand what those fears are so that we can move them to the next level and support them? So there are persons, of course, with disorders. So this is not normal fear and consideration, but also those who are clinically not well. And of course, this context, of course, will exacerbate those their fears. And again, these are people who need to be addressed in a very specific, very careful, respectful way, and and we should be taking the support to them rather than expecting them in this situation to come to us. Then this whole question about pregnant and lactating women, of course, we are told that we know of no effects of any of the vaccines, but we don't know because all of these vaccines are in test. And so people know this. One of the things that is special about this period, but also problematic, is that really and truly these things are done, usually in a lab, and the whole world is not looking on and following every step, and everything is not reported. But because everything is reported now, the changing, those of us who are scientists know that, the parameters change as you find out different things and you learn. But for the general public, changing is something to distrust, right? Changing, and if you don't explain why you change well enough, then that's a real problem. So this question of whether or not women who are pregnant and lactating should take the vaccines is something that we should also be very careful about and educate people about, what are the factual risks, but also, what they could do and what are myths. So those who are planning a family, I was really surprised that among very young people and those, in their 20s, if you notice where the slowest uptake is, among those young adults and older in our populations in the Caribbean. Many of them are really, really concerned about this vaccine really interfering with their ability to be fertile and to have children, especially the young men are concerned. Of course, all men seem to always be concerned, and they should be, about, the effects on their virility and so on. And again, this is something that is not, these are not people who are ignorant. These are genuine concerns. And for the Caribbean, as a region that already has a declining population, at our level, at the level of policy, and research, it is something that cannot be discounted. Of course, there are those who are religiously convicted, and these are all, I am listing them, but really you could have a person who is religiously convicted but has a comorbidity as well, and so on. So you can have any person, one person, or groups of people with 3 or 4 of these conditions, or which are really affecting their ability to take the vaccine, and that make them in that not yet vaccinated group. And then, of course, this question of fake adherence, right? Which is I've addressed already, and I don't want to go into it, but there have been reports not only in this country but around the world about about persons who are you know, buying the book or not taking the vaccine or all kinds of things, making fake books and so on. So we really have to consider how that works. I'm going to go to my other, where is this? Okay, because I can't see, there's something blocking my thing at the bottom here now. Okay, and then you have, you know, all these other situations. So my general point is that in terms of making putting everybody into this group of being an anti-vaxxer or being somebody who's ignorant or somebody who's resistant or oppositional or something like that, I think that is a critical error in our narratives, in our approach, but not only in terms of how we communicate about the vaccine and what we want people to do, but also in the kinds of interventions and support systems that we have in place for helping persons to be able to take care of themselves and so on. So finally, some lessons learned and some recommendations from that little breakout that I've shown you, and that is not based on you know, any kind of survey. CARP is now doing their surveys on, you know, attitudes towards the vaccine. So we're going to see some hard data coming out in the next couple of months. So these are from just, you know, scanning, talking to people, talking to our staff and students, scanning social media, looking at the papers, looking at early descriptive reports that are coming out of the context of COVID in our Caribbean. So, but it really tells us that this is not a homogeneous group of persons that we are talking about. It is a group of people with about 16 to 20 or more different variables or conditions that will constrain them. And if we can understand and remove those constraints, then we will be able to address the situation. And we will definitely have to prioritize which ones we can work with. And going back to the models that I would have shown you before, for instance, the diffusion of innovation models, or even the TTM, you know, we need to isolate which ones are in that contemplation and pre-contemplation stage, which ones are the leaders who other people will look at to see what is happening, but not only big opinion leaders, but there are people who will, you know, your neighbor next door. People are listening to those persons because they're living close to them. The lived experience is very powerful in this context as well. So in targeting, we have to understand and pay attention to those kinds of things. And those models help us to kind of construct the campaign and the response, not only in terms of a public campaign, but you can tell a person anything, but if they're not enabled, if they don't have the conditions that allow them and support their action, then they will not act. They may know that they have to act, and that, of course, creates more stress. But we have to think about getting people to vaccines where they are, you know, the movement, what their particular concerns are, if they're sick, if they're very sick, all those kinds of things. We need to change the tone of what the leadership in the worldwide is doing. And this question of really dictating to people and shouting at them and mandating them instead of encouraging and urging them, I think is something that we need to look at. We need to encourage people because we're coming from a place of respect and understanding of their lived experience, where they are, what is constraining them, rather than thinking of them as this set of people who are holding the world back by not doing what they're supposed to do so we can get on with our lives. Well, that might be so as well, but there are reasons why. And if we really want to free the planet of this, we need to therefore consider, given the fact that all of the worldwide data is telling us that the non-compliance with vaccinations is actually higher. So it's 60% or somewhere around there than those who have been vaccinated. So the vast majority of people in the world are not doing this. And so therefore we have to really pay attention to why. We need to isolate their concerns and then respectfully seek to answer those concerns and to support them. We need to admit facts, admit when we don't know, explain when things are changing, why they're changing, and speak about risks. People will take risks if they believe, but it has to be in their own volition. And if they know that there's a parameter and so on, in fact, not taking vaccine is a calculated risk because they're calculating, well, guess the chances of my getting this virus and dying is so much as against my putting it into my body and getting it. That's the simplistic calculation of many people that we have to address. Is there an alternative to the vaccine, or are there different vaccines that can be used where persons are concerned about a particular vaccine or not, right? One of the things that we need to be concerned about is the fact that people are not really, they want to be immune. Everybody wants to be immune, but they don't want to be compromised. And they feel that sometimes this may be, vaccination might compromise them. But this lesson coming out of that is that therefore we do not speak of vaccination, but immunization, right? Because that tells you something else. This says that this will make you immune, but rather than just getting jabbed with a vaccination, which of course does not tell you that there's some efficacy or something going on there, or does not point to that. We need navigators and support systems, especially for the elderly and those living alone with minimum support, no network support. There are a lot of single female-headed households in this country, a lot of them. And one of the problems of a person who is a single parent, even if it's not a female, but any single parent, would be if they have children, what happens to their children if something happens to them if they take this vaccine? What happens to their livelihood? So if you have 4 or 5 children and you have 2 or 3 jobs and you're trying to make a living and you think this vaccine is going to make you sick or something like that, then guess what you're going to do? You're going to take the risk of not taking it, because you're looking at these kids and you're wondering, who's going to take care of them? Is you're the only person to take care, you're the only breadwinner. So these are things that are to be concerned. And our government has begun to put out a safety net, but it would only go so far with the extended COVID period. So again, I come back. I'm ending now. This is my last sentence. Yes.
1 minute remaining, and you have 1 question in the audience. Would you be able to address that question?
I can't hear you at all. What are you saying? Can you type?
We have 1 minute left.
Yes.
And we have 1 question in the audience. Would you be able to address that question?
Yes. So I'm finishing now. This is my last slide. So, and I really want to say this thing about not using anti-vax and using the term anti-vax to take everybody, to include everybody. So not yet vaccinated, NYV, contemplating vaccination, CV, and contemplating COVID vaccination. So I can take the question now. And I also want us to accept that some people may never take the vaccine. Some people can't, and some people just won't. So we just have to work with those who we have and hope we can convince many. So yes, 1 minute, I am done. And thank you very much. Let me see what the question is. It's in the chat. I don't see a question. Is that a question to me? Yes.
Good morning.
Good morning.
My name is Quacy Grant, Dr. Quacy Grant.
Hi, Quacy. How are you doing?
Not bad. I was one of the students in the MPH program on health behavior.
Yes.
And as part of my MPH thesis, I just received approval from UG doing a barrier analysis on the COVID-19 uptake in Guyana.
Yes.
Proud to hear that one of Division 10. And my simple question, I know you're very busy as Vice Chancellor. If probably after this lecture discussion, it is possible to have your very much insight into the study that will be pioneered on the bioanalysis of COVID-19.
Yeah, I'm always delighted to to speak to people about work and research. At my heart, in my heart, I am a lecturer, just temporary vice chancellor, but I'll always be a teacher and a researcher. So absolutely happy to first of all make the presentation available if people want it, and also to speak with you whenever you have a chance, and also to share whatever data that we have coming from other internally in UG as well as other places like CARPA, for sure.
Thank you very much.
Okay. Well, thank you all very much. My apologies for the small glitches and typos. No, not typos, but the internet and technology glitches, but I'm still happy that I was able to present. And thank you all for the opportunity. I'll be listening to the other presentations.
Thank you so much. It was wonderful to have your presentation. It was amazing, very insightful.